Hi everyone, and welcome to the second session of Digitodontics Webinar Series. This is Mahmoud al-Bashri with you today from Digitodontics International Academy. It's our pleasure and honor to welcome our guest speaker, Dr. Chen-Ping Lin from the National Taiwan University Hospital, Taiwan. Dr. Lin will share with us his experience in how to apply digital technologies to maxillofacial reconstruction. Dr. Chen-Ping Lin is a full-time attending staff at the Department of Prosthodontics of National Taiwan University Hospital. He was graduated with the dentistry degree from the National Taiwan University. Then he finished his general resident and specialty resident training in prosthodontics at the National Taiwan University Hospital. And he became the attending staff at the Department of Prosthodontics after that. Also, he's about to finishing his master's degree in the Graduate Institute of Clinical Dentistry. So during this webinar, Dr. Lin will take us on a journey through the cutting-edge advancement in the digital technologies that have transformed maxillofacial reconstruction. He will discuss the latest tools, techniques, and software used in the field, providing the practical tips and guidance for their successful implementation. So just before Dr. Lin starts his presentation, I would like to raise your attention that you can write down your questions in the Q&A section. And after that, Dr. Lin will answer your questions. So also, I would like to apologize for starting the webinar today a little bit late. It's a technical issue, it's out of our control. But once again, I would like to thank you to join us. And Dr. Lin, thank you so much for joining us today and accept our invitation to share your experience with us.
Okay.
So without any delay, please share your screen.
Okay, thank you. Okay, good morning, good afternoon, and good night, everyone. I'm Chen-Ping Lin, working in the Department of Prosthodontics, National Taiwan University Hospital. And I'm going to share my clinical experience about applying digital tools to maxillofacial reconstruction. So thanks to Professor Mohan and that I have this chance to share this topic with you. And I first met with Professor Mohan was 4 months ago in TMDU in Japan. And thanks to ICP and TMDU, I had the chance to participate in the second YMP event and gathered many excellent maxillofacial prosthetic experts there. We had several amazing lectures, hands-on, about maxillofacial reconstruction, and have wonderful tours and dinners in Tokyo. And back to Taiwan. Taiwan is a little but beautiful country in East Asia. And we have special cuisines, traditional culture, and some famous spots like Taipei 101. National Taiwan University is one of the top tier university in Taiwan. And National Taiwan University Hospital had been the first class medical center and teaching hospital in Taiwan. As for our School of Dentistry in NTU, we have dental department and graduate institute for clinical dentistry and oral biology. In the hospital organization, we have several departments like oral maxillofacial surgery, prosthodontics, and and other departments. And I worked in Department of Prosthodontics, and we do general prosthodontics treatment like normal fixed dental prosthesis, removable partial denture, complete denture, implant prosthesis from single unit to full arch, and the maxillofacial prosthesis and reconstruction. And unlike some hospitals, we don't have an independent department for maxillofacial prosthesis or reconstruction. So we also manage patients who needs this kind of treatment and work with surgeon, communicate with surgeon and other specialists together to work with it. Head and neck cancers are a serious worldwide problem. which is the seventh most common malignancy, and with a preponderance of men. 90% of head and neck cancers are squamous cell carcinoma. As for Taiwan, Taiwan leads globally in this issue, and especially in men with 40 to 60 years of age, and is about 10 to 11 times higher than women. And there are many risk factors that leads to this condition, including smoking, alcohol consumption, and the most deadly factor which related to people with lower socioeconomic status is bitter leaf and areca nut chewing. And other factors like immune problem, infection, or exposure to certain toxins or UV light. However, not only patients with head and neck cancers require maxillofacial reconstruction. Patients suffered from like some benign tumor but aggressive tumor like amyloblastoma or osteoradionecrosis or some medication-related osteonecrosis, trauma, or genetic disorder, which cause the incomplete development of jaw dentition. They also need it. So first thing we're gonna do is to resection or to remove the lesion to make it clean and make sure we lower the chance of recurrence. And second, we need to reconstruction and reposition. We need to think about the structure that patient lost after tumor removed and try to reestablish the foundation for them based on the function and aesthetics. And last but not least, we need to help patients to rehabilitate to recover their function, including speech, chewing, swallowing, to help them back to their daily life. So we must have to begin with the end in mind. To manage patients who need maxillofacial reconstruction, we have team members including like oncologist, a plastic surgeon, rehabilitation department, and not only the physical health we need to provide, but we also need to help them maintain their mental health. So the psychiatrist and the psychologist, they also play an important role. As for reconstruction part of maxillofacial treatment, our role is to help surgeons to provide our profession in the aspects of rehabilitation during surgical planning, during surgery, and the prosthesis fabrication steps. So with the advance and progress of technologies, our communication becomes easier and clear, and we also seek for more precise and the better outcome for patient. Then we talk about the digital technologies. What's the workflow of our daily work before? Like fixed processes, we need to take impression, mounting, design, and send to a technician to fabricate and then delivery. It's also the same way to fabricate the removable partial denture or complete denture like that. So in the digital world, is there any difference? Is the steps different from the traditional one? So I would divide it steps like that, like tech impression. The first thing we're gonna do is data acquisition. We have many tools like intraoral scanner, desktop scanner, facial scan, combing CT. And by merging these data together, we can create a virtual 3D patient for us. Combing CT provides us the information of bone in terms of maxillofacial reconstruction or dental implant or orthodontic treatment to correct root axis. CT play a crucial role in the precise dental treatment. After data merging, we can create the surgical stand or processes in the softwares on the virtual patient. And later on, we can produce our like surgical stand or processes or metal framework with additive manufacturing, so-called 3D printing, or subtractive manufacturing like CNC milling. So today, I would like to share some issues we faced clinically with the use of digital tools to help us in the era of maxillofacial reconstruction. So when it comes to the malignancy, which is less common than mandible, in the maxilla. The maxillary defect is more and more challenging for reconstruction, no matter using a free flap or obturator or even implant-assisted processes. It's more challenging than mandible. And there are also some compromised functionings like speech or swallowing. For mandible, most patients were managed with squamous cell carcinoma or amyloblastoma, requires mandibulectomy, and mandible is more favorable for free flap reconstruction, like iliac flap or fibula flap. So how do these tools help us in treating patients nowadays? I will share some case and some my experience to you. And the most common cases I manage in clinic are obturators after maxillectomy and the free flap reconstruction after mandibulectomy. So I will focus on these two aspects later on. I will take two patients as examples respectively. The next question is, we expect these digital tools to help us for what? What kind of problem bothered us the most or bothered the patient the most? I think the main problem in maxilla for me is how to make a quality impression. If we had a quality impression, the following step is to fabricate a fit denture to patient. For mandibular free flap reconstruction, I would like to find out how to improve precision and accuracy in surgical planning and execution. So let's talk about the maxilla first. And this is an 80 years old woman with stage 4 gingival cancer with the maxilla bone invasion. Sorry. So what's the patient or our patient family expectation and our treatment goals? And after group discussion with her and her family, they decided to have surgery. So considering patient's age, the most important thing is her health. And then we need to reconstruct the missing hard tissue and soft tissue and dentition afterwards. So the surgeon will resect the tumor with maxillectomy, Brown's classification 2B. So as the maxillofacial prosthodontist, our interim goal is to provide a surgical obturator for surgeon after surgery. So the data acquisition part, this patient I choose to use intraoral scanner in data acquisition. I think there are several advantages. First, we can reduce the patient's discomfort by using non-pressure way compare with using like stock tray and arginal impression, which may cause pressure to the tumor site and cause pain or even bleeding. And second, bioregistration becomes easier in this situation. So we modify the model in the mesh mixer according to the surgeon's demand to fabricate the surgical obturator and then printing out the model. And wireframing and fabricate the surgical obturator. And then while excision of tumor, maxillectomy was done, and beta-iodine gauze packing in the surgical defect, and surgical obturator is well fit to the least defect. So in the first patient, we use intraoral scan to make impression to avoid the harmful impression. In the next step, we can use softwares like we trim the cast before to establish the ideal model for surgical obturator fabrication. And then we printed the model out to fabricate the surgical obturator afterwards. The second patient is a 45-year-old man. He has suffered from the mucoepidermoid carcinoma, underwent surgery in 2008. His chief complaint was his old obturator denture clasp fractured recently. And here's his old obturator. Patient also complained of food infection between the obturator and the defect. So our plan is going to refabricate a new obturator denture for him. And the most important step is making impression well. So how do we take impression in this case? And I try to use intraoral scanner to make impression in this kind of quite large and deep defect. First, I divide into two parts, maxillar part and defect parts. And there's no problem when we deal with the tooth and palate because it's solid, so it's okay. However, when it comes to the defect side, especially this kind of large defect, here are some limitations like limited mouth opening or limited to the intraoral scanner's handpiece size and angle. We cannot approach any deeper in this kind of defects. So preliminary impression of the maxillar part is okay. But how about the final impression inside the defect? So I take 3 scans about tooth and palate part, first one, and the second one, patient wearing old denture. And third part is old denture itself. And then we align these 3 scans and use softwares to produce the tissue surface corresponding to his old denture, so that I can use this model to design and produce a template. So this template serves clinically for check the precision of the preliminary impression by try-in and check tooth position, which I redesign it and make final impression inside the defect side. And we can compare with the tissue surface of old denture and our prototype. And they are similar in the tissue surface, and we're gonna use it to make impression. So we try in clinical practice and make defect side border molding and impression with soft liner. And back to desktop scanner to transfer 3D model. Then superimpose to the preliminary model and alter the defect surface to a more detailed one. And when we compare the before and after, the master model showed a more detailed and closer defect contour. And then we designed the metal framework digitally using this master model. And we'll print out this model to try in the metal framework and then finish the obturator denture and delivery. So in this case, we use intraoral scanner and desktop scanner to help us create 3D model and using softwares to align, to alter cast. Only if we get the ideal model, we can start it to design the metal framework and then finish the obturator denture with the ideal tissue surface and, and the polishing surface. So the next part, we are going to talk about mandibulectomy cases. And these years, we try to use digital tools to help improve precision and accuracy in patients required mandibulectomy. And mandibulectomy is most common like in patients with stage 4 oral squamous cell carcinoma with bone invasion in our department, or some benign tumor as amyloblastoma. And the patient with a benign tumor as amyloblastoma might have better outcome and possibility for reconstruction by dental implant placement, because most of them do not require pre or post-operation radiotherapy. Traditionally, I remember when I was intern surgery, I saw surgeon bend the reconstruction plate and to measure the defect length and the fibula flap length during the operation. And the operation time, the time cost, and the result are not quite ideal and predictable at that time. So when I started to take part in this field, our team had been trying all the way to establish a workflow that can provide a smoother and more important, precise, and reduce surgical time way. So I'm going to share our multidisciplinary workflow, reconstruction in mandibulectomy patients. And this is a 33-year-old female patient suffered from amyloblastoma. And she claimed that the dentist told her that her lesion became larger recently. Sorry. So as we see her facial profile, there are not very obvious symmetry. And we can see that her lower left teeth, posterior teeth had already been extracted several years ago. And the red dashed line indicates the lesion area. And we take the combing CT to see the lesion's position and the bony invasion area. So let's get into the surgical planning. This patient is still young, so we have to try every best to reconstruct the all missing tissue removed from the surgery. Hard tissue, soft tissue, dentition, and to rehabilitate not only function but aesthetics for her. And most importantly, we need to remove with safety margin to prevent this kind of aggressive tumor to recur. So how do we reconstruct this defect? Like hard tissue, she lost mandible bone, lost gingiva, and lost tooth. So after discussing with patient, she would like to have implant-supported fixed prosthesis in the future. So after wide excision of tumor, our team decided to have free fibula flap reconstruction with dental implant placement afterward. So let's get into the digital planning part. And here's the mandible reconstruction CT, and we mark the resection area. And we have the reconstructed lower extremity as well. And then we plane the fibula flap segment into the resection area. And there are several aspects needed to be considered, like how many segments we need, or the intermaxillary relationship we need to consider, and the contour to make sure we can keep it symmetrical, and also the direction of the blood vessel for flap to anastomosis. And later on, design the stand template for surgical use and make sure the surgery can be performed as we plan, and output by 3D printing. And we can bend the reconstruction plate and fabricate a drilling guide on the printing model before surgery. So the mandibulectomy with surgical guide and reconstruction plate fixation with the guide as well to check the occlusion. And free flap grafting and fixation to the resection area. So after free flap reconstruction, we started to plan implant after her recovery from first surgery. Her facial contour is still a little bit asymmetrical extraorally, and wound healing is well and stable reconstruction plate condition. So we can start to plan implant position. We started to think that how and where to support the surgical guide. And of course, we can support the surgical stand by dentition on the right side. But how about left side? The skin graft cannot serve a stable tissue support for them. Thus, we try to support the surgical stand on the left side bone graft surface. So we perform the intraoral scan, and we see the reconstructed bone model and combine these two models together. Like right side is intraoral scan and left side is the bone model reconstruction model. And then we plan the implant position. As we can see that the position of fibula flap is quite good as we planned at first. So we fabricate the model and surgical stand by 3D printing. So the implant surgery was done smoothly as we planned during the surgical planning procedure. So in this case, we acquire the intraoral scan and combing CT bone model for surgical planning. And in the mandibulectomy cases, we use software to design our free flap position and surgical stand. Also, we have the ability to merge the data, like combine intraoral scans with combing CT model to design the implant position and fabricate a surgical stand with both tooth dentition support and the bone support. So last one is also a case with mandibulectomy. And he is the 60-year-old man who suffered from the mandibular pathological fracture and recurrent malignancy. He would suffer from tongue cancer, status post wide excision, and adjuvant CCRT in 2017. However, not only tongue cancer recurred, but there was also osteoradionecrosis lesion at his right side of mandible, and even with pathological fracture. So since his mandible fracture, he had the problem of lip incompetence with drooling, which bothered him so much. And our very first goal is not only to remove the lesion to prevent any recurrence, but also reconstruct his displaced and destructed bone tissue to make sure that we can recover his symmetry and function. So in the surgical planning, surgeon decide to have segmental mandibulectomy with free fibula flap reconstruction. For the future processes, there will be a palatal augment processes for him because of his repaired tongue function, and implant-assisted processes may be on the mandible. So here we go. And on the reconstruction CT model, we can find out that bilateral condyle head position was changed because of pathological fracture. And that's the reason why his mandible shifted to right side. So how do we reposition his bilateral segment to an original one, to the right position? So reconstruction and reposition would be a problem, first problem. And the answer is his previous head and neck CT, which taken when his mandible was still intact without fracture in 2019. So we can take that for a reference for his original mandible or bilateral condyle position. So from this rough superimposition, green one indicates the CT taken in 2019, and gray one was in 2023. So we can see obvious positional change on both sides condyle head. So what we're gonna do is to separate the pathological fracture part here, and then take the old one as reference to superimpose them, then reposition according to the 2019 one position. So here's the CT image after superimposition, and we can see the bilateral segment are well fit to their original position. And so that we can start to plan the defect site based on the corrected bilateral condyle position and mandible position. And here's the section guide and position stand, and the section guide to fibula bone. And then mandibulectomy with surgical guide, remove tongue cancer tumor site. And then we reconstruct the defect with free fibula flap after fixation from positioning stand. And the post-operation profile, we can find out that we successfully reposition his mandible, and his mandible becomes symmetrical, and there's no longer drilling anymore when compared to the initial facial profile. In this patient, we utilize former combing CT as a reference to reposition his displaced mandible and make sure we can execute it right by using surgical stent or positioning stent. So as the science and technologies and devices progress and improve, and there are more and more tools that we can use to help patients and ourselves to perform precision medicine. However, before using these modern technologies, only if we understand the principle and limitation of them, we can just get the more precise, reduce surgery or laboratory time, and better outcome to patient. So last but not least, here are some reflection from my topics. And first, teamwork and communication is always necessary and important, and they can help each other becomes better and better. And as a prosthodontist, I still learning the surgical knowledge every time during surgical planning and discussion. And we also have to have our goals in mind before we leave so that we will not get lost. And knowing the advantage and limitation of digital tools is necessary before using it. So on the recent AI trend, some of this work might rely on AI's help now and in the future. So special thanks to the OMS team, Professor Chen and Professor Chen, and NTUH Digital Center and Digital Can Tech Company for 3D reconstruction technique support, and Arch Dental Company for some laboratory support. So thank you for your attention, and any comments are welcome.
Very inspiring and interesting lectures that you presented to us. You dived us to the many aspects that are very important to provide a prosthetic rehabilitation and functional rehabilitation for maxillofacial defect patients. You went through the maxillary defects, then you moved to the mandibular defects, and you showed how the advancement of digital technology is changing the way we treat our patients. So I would like to thank you for this nice presentation. So let us see if there's any questions from the attendee. Please don't try to ask the disadvantage and ask any questions that you think or you need the answer for those kind of questions. So Dr. Lin, you mentioned that using digital technologies can change a lot in terms of the patient expectations and in terms of the workflow itself. So you mentioned also about the challenges, and I guess one of them, the technology cost. So how do you overcome this issue in your institution?
You mean the cost?
Yes. Because I saw some of the softwares that you use is open source softwares. Others are a commercial software. Yeah.
And in our NTUH Digital Center, and we have made some of the software was sponsored by the company, and some of them was bought by us, by our university, and some of them are free. So like 3Shape or XOCAD, and they are sponsored by the companies, and we help each other. We try in every kind of clinical situation, like to help them. Then also we have some lecture to help promote or to improve, to correct their softwares, to help each other. And some planning part, 3D printing part, and a company, a digital can company, they help us to 3D print this kind of material. And of course, there will be a cost after the surgery. So we will discuss with the patient about, we will have a digital planning, unlike traditional, we measure or section the tumor during surgery. we may have a more precise or reduced operation time, but we will have another cost will not covered by our health insurance. So patient will agree. I will show some result and the steps to him or her, and they will agree or not agree to have this kind of planning. Yeah, so some cost will need patient to cost. Yeah.
Yeah, thank you so much. You showed us in one of the cases, specifically for the mandible case, that taking previous data is a great advantage to provide, yes, this one, to
Yes.
provide a great results. So do you think that with the technology, digital technology, because we will not have any kind of issue regarding the saving the data and everything. So do you think that taking a regular record for the patients is very important, especially for the oncological patients?
Yeah, I think it's very important because at first I met this patient and I discussed with the surgeon about like, oh, his mandible is fractured and the bilateral condyle position was wrong. So we cannot just remove the necrotic part and to plan the fibula flap on this kind of position, right? So we're trying to figure out how to reposition his bilateral condyle head. So an idea come to us mind that this patient, we find his medical record in our hospital, and then we find out that he had taken head neck CT before. So like it's kind of lucky.
Yeah.
So we utilize this kind of CT to reposition his condyle head position. So I think, and so I think that this kind of record is very useful for patient. So not only the CT image, maybe we can copy it as a CD for CD to patient. And maybe some days he went to other country or other city, he met the same problem in the future, and he can still use it as a tools or reference for surgery. And I think not only the this kind of combined CT, maybe some intraoral scan, and maybe can be provided as a record to patient for the like the cast, the model we saved for patient who finished the treatment, and maybe it's useful one day for them in the future. So in this case, it's a little bit lucky that patient had CT DICOM file before, so we can take it as a reference and replay reposition the condyle head well in this case.
Yeah, yeah. So do you routinely use the intraoral scanner to keep the record of the intraoral dentation and anatomical structure? Do that
not very often for every patient. And sometimes if the patient had underwent like severe like worn dentition or very large scale full mouth reconstruction, and I will save their model or even intraoral scan, and maybe for them or give it to them to as a reference for them. Yeah, but not every patient. Yeah.
Okay. Is that because of the time limitation or the intraoral scanning limitations, or what main reason not to taking every case digital records?
It's because it's the time limitation and the limitation that our clinic at only 1 to 2 intraoral scanner.
Okay.
Okay, now. So maybe it's maybe more in the future. So So, but the file will not be deleted to maybe 5 years to 10 years.
Yeah.
So maybe it's a chance I will take every intraoral scan for patients. I think especially because in our graduate institute, we have some research about the in vivo study about the hybrid ceramic material and the wear condition. So we will keep the patient who just received the hybrid ceramic overlay treatment, and after 3 months follow up, 6 months follow up, we will keep their intraoral scan to compare the tooth wear condition like that. So in that kind of condition, we will save their intraoral scan model for this kind of comparison now. Yeah.
So we have one question from Dr. Chiu Fong Wu. Thank you, Dr. Lin. Very amazing and informative presentation. Digital archive is a very powerful tool. Do we have the opportunity to track patients' conditions during different periods and create a digital avatar? So this is his question.
I think to track patients' condition during different periods, like in the follow-up stage or the treatment stage. For example, like the reconstruction plate or the mandible connected area is stable or not, and we can follow it, or in other kind of case. I think it's possible, but we still have to maybe we can add facial scanner because because the intraoral scan or facial scan, intraoral scan or combined CT just mean the dentition part and this patient's bone information, but we still not have patients facial profile or soft tissue profile. So maybe in the future we can add the soft facial scan into it to make a digital avatar at now, and then compare to the past and in the future about not only the hard tissue or dentition change. And with facial scanner, we can also see the to observe if there's any soft tissue or facial profile change. So I think the meaning of tracking is about it's mean to see that if as I think it's about vertical dimension in the severe wear-worn dentition patient, we can track that maybe after treatment and post-treatment 1 year, 3 year, 5 year, we establish an avatar to observe that if there is any dentition wear or vertical dimension loss during the follow-up stage or in the maxillofacial reconstruction part, and we can see that if there is any change in soft tissue or hard tissue.
Yeah, I think that's will open doors for research projects and opportunities, because we need to go to that directions. even using the AI that will play a great role in attracting patients before and after, and even during the treatment. So yeah, that will be a great research direction for the field, I guess. So I think with that, we are going to conclude our session today. So once again, I would like to thank Dr. Lin for his time that he shared with us very valuable information that help us to understand those kind of patients and how they are treated and everything. So once again, Dr. Lin, I would like to thank you for your time and effort for today's webinar. And
thank you very much.
Yeah, and as a tradition for Digitodontics, we would like to present the certificate of appreciation. We hereby express our sincere appreciation to Dr. Chen-Ping Lin in recognition of his contribution as a live webinar speaker for Digitodontics Webinar Series on topics of how to apply digital technologies to maxillofacial reconstruction. That was presented on Thursday, July 6, 2023. Once again, Dr. Lin, thank you so much.
Thank you very much.
Thank you.
Thank you.
For everyone, I would like to thank you for your time to join us today to get this valuable information from Dr. Lin lecture today. And please be told that we have bunch of webinars in the coming days, so don't hesitate to come again and register for those webinars. So for you all, thank you so much and have a nice day, a nice evening, and a nice morning as well. So thank you so much all. Thank you.
Thank you.
Thank you.